Hello, everyone, and welcome to the Medical Trauma Support Podcast. And today I am talking to Nic Schmoyer-Edmiston. And Nic, do you want to tell us a little bit more about yourself and what you do?
Sure. So, like you had said, my name is Nic. My pronouns are he, him, and his. Currently, I am an assistant professor in the Department of Counseling at the Philadelphia College of Osteopathic Medicine. So I teach master's level coursework for counseling students who are interested in becoming clinicians and researchers in the field.
Mm-hmm. Cool. And osteopathic medicine isn't as common or mainstream as kind of like Western medicine as we know it in this country. So will you tell us about what osteopathic medicine is?
Yeah. So at least my understanding of what osteopathic medicine is a more holistic approach to what medicine could look like, where physicians from this perspective will integrate the mind and the body more intentionally throughout treatment. And sometimes this might include incorporating the body's natural ability to heal within various different phases of the treatment process. So this might include things like an osteopathic manipulative medicine approach, where folks will use the musculoskeletal system to assist with the body's natural healing process. So again, osteopathic medicine is really this holistic approach to what medicine could look like.
I love that. That's really beautiful. I think recognizing that our bodies are pretty magical.
Yeah.
I kind of say that to my kids, when you think about, and obviously sometimes we do need extra support to heal. Oftentimes we do need extra support, but just the fact that we can get a cut on our arm and it can heal, I think sometimes we lose sight of the fact that that's pretty amazing.
Mm-hmm. Absolutely.
Yeah. Yeah. So, Nic, when we first met and talked a little bit, we talked about your focus the area that you research, which is integrated care. And I'm wondering if you would talk a little bit about what integrated care is, some of the different terms it goes by, and we'll start there.
Sure. So integrated care is also referred to as integrated behavioral health or integrated primary care. The way that I typically phrase it in a much easier way is IBH. So I'll refer to it as IBH moving forward. But essentially, this is a process of care where medical and behavioral health clinicians are integrated into the same settings towards the goal of providing efficient, cost-effective, and person-centered care for the wide range of biopsychosocial spiritual needs that someone has.
That's really wonderful. The person-centered care, I think, really makes all the difference. And especially when people are going in to get care in really vulnerable times of their life, and being able to incorporate all of it. Whereas I think sometimes medicine feels like you're walking in and one piece of you is being treated, but we're so much more than that.
Absolutely.
And I think that's also where some of the trauma can come from, is when we're seen as just a part of something and we're not seen as this human with this whole lifetime of experience coming in and sitting with somebody.
Absolutely.
So
yeah,
I think that's beautiful.
And especially within the current models of care, we more or less use what's called a coordinated approach, where your primary care physician is right here, and then a mile down the road is your therapist, and a mile down the road from there is your specialist, and then a mile down the road from there is your hospital system. So really what that integrated care approach looks to do is combine them as much as possible so you can get your behavioral health needs and your physical and medical needs met in the same setting, while also still recognizing that some folks need and deserve that higher level of care.
Yes. Yeah. I've been reading this book that talks, it's called Healing. It's Our Path from Mental Illness to Mental Health. And they do talk a lot about that and ways that we can improve mental health, which I think is overall health in this country. And that is to have the care, like you're talking about, the integrated care, and making it easier for people to access everything they need in one spot.
Absolutely.
And, and when you talked about 1 mile away, for so many people, 1 mile would be whoa, they're so close. Because especially if you're living in rural areas, which so many people are, it's sometimes the care isn't even there
Absolutely.
in
And
your area.
I will say that is another big, I guess, like gap that this integrated care piece hopes to address, in that it makes everything more accessible.
Yes.
Where there's a huge shortage of specialty mental health providers. If we can put our behavioral health clinicians in primary care, in specialty care, where people are already getting the care that they need, we're already improving accessibility and reducing the amount of stigma that comes alongside behavioral health care.
Yes. I love that. So I know that's your area of research. What are you seeing as far as like that getting integrated? It sounds like y'all are doing a great job at integrating it into the osteopathic
Sure.
medicine world. Where are we right now, kind of overall? I'm not seeing a lot of it.
It's growing in prevalence. There
Yeah.
are a lot of like university hospital systems and community health centers, particularly your federally qualified health centers, your FQHCs, that are
Okay.
doing integrated care spectacularly and amazingly. And that being said, it's still growing. Um,
Yeah.
what we're finding is we need to shift a lot of the way that we conceptualize health and healthcare to better fit this model. And right now, we're still very entrenched in that traditional, like, coordinated care approach where everything is separate and everything is siloed, because it has worked for some people for a very long time. But what we're seeing moving forward is that we really need to start integrating our behavioral health into our mental care, into our medical care, and vice versa.
It's it's so funny that mental health is separated
Mm-hmm.
out from all of the rest of it, and it doesn't make sense. And I think stigma is a big part of that, and that's also a big part of why there's stigma.
Yeah.
But it's like to I don't know when it first happened. I probably need to read up on the history about it, but like why would that ever be separated? That's just like we are one human,
Mm-hmm.
and mental health is just one piece of our overall health. And so it should be treated
Mm-hmm.
it's like we would go to the doctor for a broken arm, you know?
Absolutely. And, there are folks within the integrated care field that are saying that, like, even conceptualizing it as medical health care versus behavioral health care might even be ineffective because behavioral health is health care. So why not
Mhm.
refer to all of it as just general health care?
Exactly. I even have a hard time when I talk about supporting people with mental health. I want to just say I support people with their overall health, but I know that right now the words that people are used to they expect to see mental health if I'm supporting somebody in that way, but I do think it's overall health.
Mm-hmm.
Um, I love that. And then, you know, within that and medical trauma, how does that look? Like, how does this integrated care? I mean, you've shared a bit about how that's going to help minimize, possibly prevent medical trauma for someone. But do you have like kind of an example of the ideal situation
Sure.
that integrated care would help that?
Yeah. So I will say, like, and I'm sure within the field, like, medical trauma is still kind of getting up and running in the research base. There's not a whole
Yeah,
lot out there, but there
right.
have been some very, like, meaningful calls to action for us to start integrating medical trauma into training and clinical spaces. And what this might look like is having a behavioral health provider at all different levels of care. So not
Uh-huh.
just within our primary care settings, but also within our specialty clinics to help
Yes.
folks process a new diagnosis or to process surgical experiences in the specialty setting, but also in our general hospitals where folks might need intensive care unit treatment. Having a behavioral health provider available to someone once they wake up from an ICU stay or
Yes.
they wake up from an emergency surgery as a result of like a heart attack or a stroke could be the difference between someone being able to fully process that experience and someone essentially being left to process it themselves but not having the tools to do so.
Right. I mean, yes, I think with any traumatic experience, basically what happens right after
Mhm.
is so crucially important.
Mhm.
And you know, you talked about somebody waking up in the ICU unit. Yes, it makes so much sense. And that is one area where more of the medical trauma research has been done
Yes.
because it is so common when you've had an ICU experience to be
Mhm.
left with a lot of trauma.
Mhm.
And that really makes me think too about something else that you and I talked about, which is the Enduring Somatic Threat Model
Mhm.
and looking at medical trauma from that perspective and understanding that medical trauma is different than a lot of other types of trauma. And the Enduring Somatic Threat Model is a way to approach
Mm-hmm.
supporting people with medical trauma. And I would love it if you would talk a little bit more about what the Enduring Somatic Threat Model is and how you use it.
Yeah. So I guess first I want to very briefly touch on like what are the traditional conceptualizations of trauma. It's that there's this external stressor that proves some sort of perceived or real threat to life. And because of that external stressor, our brains and our bodies kind of readjust to keep ourselves safe. And then we engage in patterns to help maintain that safety. But over time, that safety behavior no longer becomes super helpful or functional.
Mm-hmm.
But again, the big piece of those like traditional trauma models is that there's an external stressor, something that can be escaped or removed from in some capacity.
Right.
Now, within this enduring somatic threat model, we're recognizing that the threat for chronic illness or medical emergencies isn't necessarily external, but it's internal.
Mm-hmm.
There is something that disrupted our bodies in some way, shape, or form that required some sort of immediate treatment or ongoing treatment. And so now the threat isn't external, it's internal.
Right.
There's this constant reminder through our somatic symptoms and our medical appointments and the thoughts that we're having about our own life and mortality that there's not really this idea of safety from initially.
Right.
Because
And it's ongoing. It's ongoing, whereas oftentimes with the traditional PTSD model, it's in the past. It's something that happened in the past and you can move forward. But yes, with this enduring somatic threat, it is ongoing. It's kind of like past, present, possibly future, depending on what has happened.
Absolutely. And for a lot of folks who are experiencing medical trauma, at least from my experience, there has been like this awareness of their own health and potential that they might die from something like this. And that is something that isn't always prevalent in traditional conceptualizations of trauma, where like our body recognizes that we were unsafe in this external environment, but now we're trying to like grasp our head around like my body has changed in some way. And now there's this constant threat that I'm constantly re-experiencing through chest pain or difficulty breathing or other very common like physiological experiences.
Mm-hmm.
So again, it kind of separates that idea that the trigger was external because now the triggers and the experience was internal.
Right. And we're also being asked to be hypervigilant about our health in many situations. You know, we're being asked by our medical providers, if this happens, you need to do this. Look out for this. You need to come in every 6 months or 3 months or whatever it is. So even beyond what we're experiencing alone, we're being told that to stay alive and to stay safe, you need to be hypervigilant about your health.
Absolutely. And that hypervigilance is a very common piece of like post-traumatic stress disorder and other trauma responses. And a lot of times what we might find is that traditional like manifestations of hyperarousal also parallel some of the medical symptoms that someone might have experienced in an emergency.
Yes. So it's like re-triggering that, you know, it's like, yes, it's hard. It's really challenging. And I mean, I think hopefully will help people that are feeling this every day know, of course you are. Like it's normal that you would feel this, right? And you're not alone. I mean, it's so common and prevalent that there are people researching it and talking about it. Not enough yet, right? There's like not enough people. In fact, Nic, I found you because I was just doing some reading and research myself and found one of the articles that you wrote about this and was so excited to find somebody else doing the medical trauma work, but on the research side. So it's really cool to get to talk to you about this.
Yeah.
I think, you know, the other thing and a big part of what I like to focus on is like, okay, so yes, these things are hard and we can use this newer model to help people in their healing journey, or, you know, whatever phrase they want to use about starting to feel better, feel more like themselves again. So Can you talk a little bit to like how you use this model when you are helping people?
Yeah. So, um, one of the ways that I've been able to use this approach that like we're moving the trigger from external to internal is this idea of like almost acceptance of like
Mm-hmm.
this is the new normal for our bodies, and just because it's a new normal doesn't mean that it has to be a bad new normal. So now
Mm-hmm.
we're looking to integrate new experiences and how we can tell, okay, this is me experiencing a trauma response versus
Mm-hmm.
me experiencing a medical emergency. And that does require quite a bit of like awareness of your own body and your own process for these.
Mm-hmm.
Another really common experience related to PTSD as a whole is this avoidance of
Mm-hmm.
triggers and experiences. Now, in like a medical trauma experience, the avoidance is it typically manifests as avoiding healthcare settings and avoiding
Right.
appointments and avoiding lifestyle changes that might again mimic the initial experiences. A very common
Yeah.
example that I've seen is like folks who might have experienced a heart attack. One of their primary lifestyle changes is to increase more meaningful exercise into their
Mm-hmm.
lives. But one of the things associated with exercise is a rising heartbeat and pain in the
Right.
muscles and shortness of breath, all of which could be reminders of what that heart attack was like. So now we're
Yeah.
starting to look at how can we help you re-engage with the things that are going to be meaningful for your ongoing health, while also maintaining some level of like self-compassion and
Mm-hmm.
awareness that this is my body's natural process. It does not necessarily mean that I am in danger in this moment.
Right.
So looking towards ways that we can meaningfully reintegrate like positive health behaviors or helpful health behaviors in our life, while
Mm-hmm.
also holding true that like my body has experienced something very scary and stressful, and it's going to take some time to adapt to it.
Mm-hmm. And what are you doing to help people get to know? I think a lot about polyvagal theory and our nervous system and getting to know and befriend our system. And so what kind of strategies do you use with people in order for them to get more compassionate, get to know themselves, their bodies better?
Yeah. So truly, I don't have like a specific approach because I really leave that up to that person.
Hmm.
Kind of like how we talked with that integrated care approach where the care is person centered.
Right.
I come from the perspective that like individuals know what works for them, and right
Hmm.
now what works for them is inaccessible for one reason or another. So how
Right.
can we help you get a little closer to what is already accessible to you?
Yeah.
And sometimes that means engaging in mindfulness. Sometimes that means engaging in like an examination and disputation of unhelpful thoughts and feeling and behavior patterns. So there's
Mm-hmm.
not like one go-to that I experience
Yeah.
that I lean on. It's a very like individualized, tailored approach to how can we help you start to feel more comfortable in your body after this very real stressful event that you've experienced in your body.
Yes. I love that so much. Just that whole idea of people know,
Mm-hmm.
people know, like we have it inside of ourselves, but sometimes, oftentimes, we need some help,
Mm-hmm.
like having like, a guide or a support remind us of what we know deep inside that can sometimes get hidden.
Mm-hmm. And I know my like theoretical approach to a lot of these is a mixture of like cognitive behavioral therapy and acceptance and commitment therapy. So helping
Okay.
folks recognize like what are the patterns of thoughts and feeling and behavior that are like perpetuating these,
Hmm.
and how can we learn to accept and integrate these things while simultaneously moving in a values filled direction.
Yeah, I love that. And, I like to end with asking, the person I'm talking to if there's anything that we didn't talk about that you want to make sure people hear, and also letting us know about work you're doing or things like that.
Yeah. So from the like the patient side, one thing that I'm an active advocate for, especially within the context of integrated care, is like checking in with your primary care providers and your medical providers. What behavioral health services are available to me?
Hmm.
What's available here or in the community that can be beneficial for me managing this? And sometimes what this might look like is saying, like, what would it be like for us to have a behavioral health provider in here with us? And truly, that patient experience is incredibly beneficial and might be part of the catalyst towards more intentional integration of behavioral health providers in our medical settings.
So that's something that people as patients and clients can do, is to start to ask for it.
Absolutely.
To ask about it, to ask what the options are, and to ask for it and say, it would be really great if I could come here and I could get these services. And it doesn't mean it's necessarily going to happen, but
Absolutely.
it's at least planting that seed. What it reminds me of is my kid's pediatrician office is doing CBT work with kids, which I think is really cool. Like, you can sign up and go see, I think it's one of the nurses, and do a little bit of CBT work.
Absolutely.
It's a step in the right direction.
Yeah. And the patient perspective on like this holistic approach to healthcare is like a very important piece of the research in integrated care right now. What we're finding is that one of the goals of healthcare broadly is to enhance patient wellness and satisfaction with care. And by and large, folks that have integrated behavioral health services in their medical settings tend to perceive their care as more effective and efficient, and they tend to be more satisfied with it. And so, like, advocating on that on multiple levels, so not just you and I advocating for it from like the professional side, but also patients advocating for it, saying like, I think this would be beneficial. Can you at least entertain this idea?
Right.
Might be a very helpful catalyst to making it more commonplace.
Yeah, that's great. And is there anything else that you're working on that you want to tell people about, or anything coming up?
Yeah, so I will say a lot of my research is focused on how we can train behavioral health providers for integrated behavioral health settings. And I'm a big, one of the most common things that I will say to all of my students that I have is, it's not a matter of if you will encounter someone who has a chronic disease or a medical emergency. It's more of a matter of when. So how can we begin to integrate these conceptualizations and this knowledge about biomedical processes that have typically been like miles and miles disconnected from our behavioral health training?
Right.
And with this in mind, that medical trauma piece is incredibly important because, again, not every person that experiences a traumatic medical event will go on to exhibit PTSD or PTSD symptoms, but some folks will. And the folks that do deserve high quality treatment in the space that they're already receiving care.
Right. In the space that they're receiving care that was often
absolutely
where the medical trauma happened. So being able to do that care there.
And at least from my perspective, that's a huge part of what this treatment could look like. Where, again, part of this avoidance is we're avoiding medical settings now and medical tests.
Right.
Now, if we can establish safety in the spaces where they occurred, we can start to reduce some of that avoidance and start a very meaningful process towards not just healing, but also prevention and health-related behaviors that will help extend longevity.
Right. Yes, I love that. Holding up that dream for the future. And I love that you're doing that work. Like, I mean, you're one of the people that is working to make that happen. And so thank you.
Yeah, absolutely.
Amazing. All right. It was so good to talk to you today, Nic. I've been looking forward to this since we planned it because I knew it was going to be just a really cool conversation. So thank you so much.
My pleasure. I appreciate the space to do this and to have these sorts of conversations. I know that it is a challenge to find clinicians that are trained in like chronic illness and medical trauma. And we're starting to see more and more folks are prioritizing it in research. Yeah. And a lot of times research is what starts the catalyst in education and clinical practice. So,
right. Yeah. So good things are coming. Good things are on the way. And for now, I have been able to find some people that are aware of medical trauma and have been doing that work to support people. But I just think it's going to keep growing. And because of people like you doing the research and then educating the future clinicians that are in school right now.
Absolutely. So. And I do want to also like recognize it's not just going to be like us on the professional side. Patients also have a huge part in this, where if they ask for it and they show that there's a need for it, health systems might respond.
Yeah. So I think that's a call to action to everybody listening, is you do have more power than you probably even think you do. Because oftentimes it can feel like you don't have any power in the medical system. And I think that's a piece of the medical trauma as well. But
Absolutely.
you do have power because you are the one paying. And so you're the one showing up. You're the client, you're the patient. So just even planting little seeds when you're there with medical providers is going to just slowly continue to move the system forward into a more integrated, supportive space.
Absolutely.
All right. Thank you, Nic.
Thank you.